the methods for monitoring resuscitation. Welcome to the Everything Surgery podcast, where today we are diving deep into the essential topic of monitoring resuscitation. In this episode, we will guide you through the dynamic and critical process of ensuring that resuscitation efforts are effective, how to steer further therapy, and how to watch out for complications that may arise from both the underlying condition and the treatments given. The process evolves from simple and immediate assessments to more complex and invasive methods as the patient's condition requires. Let's get started. The key philosophy behind effective resuscitation monitoring is a multi-parameter approach, as no single measurement can provide a complete picture. So, we categorize monitoring strategies into several important levels. First up is clinical monitoring, the hands-on assessment. This is the fundamental and immediate approach, available in every setting. We start by observing vital signs. For example, a decreasing rapid heart rate often signals that resuscitation is working, whereas a persistent or rising heart rate suggests ongoing fluid loss, pain, or other stressors. Blood pressure is another vital sign, with the main aim being to restore and maintain adequate organ perfusion. Although systolic blood pressure is important, mean arterial pressure is a better indicator for perfusing vital organs, with a typical initial goal being greater than 65 mm of mercury. Next, we assess respiratory rate. A rapid breathing rate can indicate low oxygen, metabolic acidosis, or sometimes pulmonary edema caused by too much fluid. Temperature monitoring is also vital, especially in severe infections or after cardiac arrest. Physical examination is equally crucial. Improved mental status, such as alertness and cognition, signals better brain perfusion. On the other hand, confusion or agitation may mean low oxygen or ongoing shock. Assessing skin perfusion is also informative. Capillary refill time of less than 2 seconds is a good sign, while prolonged refill suggests shock. Warm, dry skin typically indicates improved perfusion, whereas cool, clammy skin is a classic sign of shock. Strong, palpable peripheral pulses such as those at the wrist or foot also point to adequate cardiac output. Listening to the lungs is essential to detect early signs of fluid overload, such as crackles. We then move to basic non-invasive monitoring, which provides us with continuous and quantitative data. Pulse oximetry monitors the saturation of oxygen in arterial blood, and the target is generally above 94%. The waveform from pulse oximetry can also indicate the quality of peripheral perfusion. Continuous electrocardiogram monitoring is necessary to watch for irregular heart rhythms, which can either cause or result from shock and shifts in electrolytes during resuscitation. Urine output is another critical indicator, as it reflects kidney perfusion. The target here is more than half a milliliter per kilogram per hour in adults. A decline in urine output is often one of the earliest signs of inadequate resuscitation, while improvement is a positive indicator. For patients who remain unstable or are not responding to initial therapy, especially in the intensive care unit, advanced hemodynamic monitoring is used. An arterial line provides continuous, real-time blood pressure readings and easy access for repeated blood gas sampling. Monitoring central venous pressure, which reflects pressure in the superior vena cava near the right atrium, has historically been used to assess volume status, though its utility is debated today. Rather than relying on a single value, observing trends over time, especially after giving fluids, can be useful in determining whether a patient will respond to more fluids. Central venous oxygen saturation, measured from a central line, shows the balance between the oxygen delivered to and consumed by the tissues. A normal value is greater than 70%. In shock, a low central venous oxygen saturation suggests that tissues are extracting more oxygen due to inadequate delivery, making it a crucial target in early goal-directed therapy for severe infections. Blood gas analysis is another cornerstone, measuring acidity, bicarbonate levels, and base deficit or excess. Resolving lactic acidosis and an improving base deficit are primary goals during resuscitation. Serum lactate is considered the gold standard for detecting tissue hypoperfusion. Levels above 2 millimoles per liter indicate anaerobic metabolism due to insufficient oxygen. Monitoring the trend of lactate levels over time is more informative than a single value, and a decreasing level is a key marker of successful resuscitation. Emerging minimally invasive and non-invasive technologies now allow us to gather even more detail on the cardiovascular system. These include esophageal Doppler, pulse contour analysis, and thoracic bioimpedance. The main parameters measured are cardiac output, the volume of blood the heart pumps each minute, and cardiac index, which adjusts this volume to body size. Stroke volume and stroke volume variation are especially useful. A high stroke volume variation is a strong predictor that the patient will benefit from additional fluids. Systemic vascular resistance helps us distinguish types of shock, with low resistance common in septic shock and high resistance in cardiogenic or low volume shock. To bring all of these elements together, we use a practical and integrated approach, often referred to as the resuscitation bundle. The most important takeaway is that trends in measurements are far more meaningful than single numbers. It's the patient's trajectory that guides us. No single parameter is perfect, so we must always combine clinical examination, vital signs, laboratory data, and advanced monitoring for a holistic view. The ultimate goal is to restore adequate tissue perfusion, not just to reach a specific blood pressure. Remember, the mantra is to treat the patient, not just the monitor. And always keep an eye out for complications such as fluid overload leading to pulmonary edema, or disturbances in electrolytes. Thank you for tuning into the Everything Surgery podcast. If you found this content helpful, please like, share, and subscribe. Stay tuned as we continue to dissect the extraordinary.